Good afternoon, everybody. Thank you so much for joining us. We're excited to have a very timely conversation today about the intersection of vision health and public health in a post-COVID world, and talk about how we can creatively work together through public and private partnerships to create sustainable solutions for sight that not only help the blind and visually impaired, but fit within our public health infrastructure in our world today. So we're very excited for our two guest panelists that will be talking with us today. And with that, it's a couple minutes after 12, so we're going to go ahead and get started. To provide some context, I want to start with a presentation, and to do that, I'm going to start a brief screen share. All right. So the topic of today's conversation is the intersection of vision health and public health in a post-COVID world. Again, this is a conversation on public and eye health and nonprofit partnerships in a changing health industry. It's a very timely topic as we start to get back to something that more closely resembles what our lives looked like 2 years ago, but nonetheless is fundamentally different than what our lives looked like more than 2 years ago. So we're really excited to share this information with you today, starting with just a little bit of an overview and connection between vision health and public health. We want to make sure that we're using the same terms and understand the context of this conversation. Lions Vision Services and I know Dr. Kuruvilla with the Eye and Laser Center are looking at this from a uniquely vision health oriented perspective, but we need to understand how that fits in the public health arena as well, like what Scott does at Atrium. So we want to talk a little bit about that. Most of our time today is going to be a panel discussion where the three of us talk through some of these issues and questions. And I invite all of you that are attending to participate in this. We'll do our best to monitor the chat, but if you have a question for us, if you could use the question and answer function in the Zoom platform, that would help a lot to help us flag those questions and make sure we address as many of them as we can. We are going to leave some time at the end for questions from the audience so that you can participate in this conversation. And if you're watching this at a later date, we hope that you will find this helpful, and feel free to reach out to us at Lions Vision Services if you're watching this later to continue the conversation with us. So with that, we're going to start with vision health and public health and provide a little bit of an overview here. We know that if all the current trends hold, that without effective intervention by the year 2050, every major eye disease is going to see significant increases in its prevalence. And particularly, the number of blind and visually impaired people worldwide is going to double just by the year 2030. So we've begun a decade in which we're about to see vision health place an unusually significant strain on an already strained healthcare system. These are important trends for us to keep in mind. Vision is something that is fundamental to every aspect of our life. A resolution earlier this year by the United Nations connected vision health not only with good health and well-being, but with nearly a dozen of the Sustainable Development Goals that outline a blueprint for a healthier community by the year 2030. So vision health is not just about good health and well-being. Unoperated cataracts can increase the likelihood of a vehicular accident in a city by as much as 2.5 times. So there's a connection to sustainable cities and communities as well. Eyeglasses can significantly increase the likelihood of children being able to advance in education. So there's a connection to quality education. The eye health industry and the health industry as a whole makes a contribution to the carbon footprint that we see. And so there's a connection to climate action as well. And many eye conditions can be created or exacerbated by climate impacts and climate change. So there's a two-way connection there. So lots of relevance for us with vision health and with other aspects of our lives. We also see connections between vision health, public health, and poverty. You can see in these three maps the counties that have the largest percentages of their population, blind and visually impaired, tend to be overall the counties that are least healthy, according to the Robert Wood Johnson Foundation, and tend to be counties that are most likely to be experiencing poverty. So there's going to be overlaps in how we encounter communities that are needing vision services, and those same communities needing access to services and access to public health beyond just sight. We know that people with severe vision impairments are significantly more likely to have diabetes, arthritis, and mobility issues. That's what those three graphs are there. The one on the far left is diabetes, and then arthritis and mobility issues from left to right. And we know that vision loss is related to a host of other health conditions: depression and isolation, stroke, hearing loss, balance problems, risk of early death. Again, it underscores the connection to many areas of our life. So what's the role of public health in all of this? We know that from our standpoint at Lions Vision Services, the nonprofit community is just one part of a government and public health infrastructure, an infrastructure that is robust, that is incredibly diverse, and that involves a host of other care systems, community partners, and industry alliances. We know that with just the context of the coronavirus, the effects of COVID-19 are exacerbated with individuals with existing chronic diseases. People with diabetes are more likely to have the coronavirus, and people with diabetes often have vision loss as well. There's a host of primary, secondary, and tertiary levels of prevention that addressing vision in the context of public health will help to create other positive secondary benefits to public health initiatives and infrastructure. We can help advance public health by addressing vision first. We also want to underscore the connection between vision health, public health, and the social determinants of health. We know that those social determinants of health include education, access, and quality, economic stability, social and community context, neighborhood and built environment, and healthcare access and quality. Another useful data source for social determinants of health is the CDC's Social Vulnerability Index. This is an index that was calculated at the county level using 15 variables from the United States Census. It provides a composite measure of a county's overall social and economic vulnerability. Maps on the CDC's website allow you to visualize county level vulnerability and compare that to the county level prevalence of serious vision loss and diagnosed eye disease. This county will probably look very familiar to our guests, to Scott and Dr. Kuruvilla. Lancaster County is in the Catawba region of our state, just outside of Charlotte. And you can see a lot of the consistencies here between the total overall vulnerability index of the community, and then specific breakouts of socioeconomic status, household composition and disability, race and ethnicity, and then housing type and access to transportation as well. And the Vision and Eye Health Surveillance System at the Center for Disease Control offers a lot of county level data points that help us compare these trends in social vulnerability to vision and eye health. The current breakdown of that data is less accessible within specific counties like these other CDC social vulnerability indexes. But nonetheless, we can still see some county level data on vision loss that helps to show correlations between public health and vision health initiatives. So that leads us to our conversation today, and we're very excited that we have two outstanding individuals in their field that are agreeing to join us and to lean into some of these questions and some of these trends to talk with us about this. And I'd like to take just a moment to introduce them to you. Dr. Oscar Kuruvilla grew up in the Philadelphia area. He attended Case Western Reserve University in Cleveland, Ohio, where he graduated with honors and with a Bachelor of Arts degrees in biology and psychology. From there, he moved south to Columbus, Ohio, and completed medical school at Ohio State University. During this time, he completed a course in traditional Chinese medicine in Wenzhou, China. He finished his internship and residency in ophthalmology at the Henry Ford Hospital in Michigan, where he served as chief resident. He completed a fellowship specializing in diseases of the retina at Vanderbilt Eye Institute in Nashville, Tennessee. His areas of interest and specialized training include diabetic eye disease, macular degeneration, with additional training in uveitis. And in addition, he practices general ophthalmology with a particular interest in cataract surgery. He prides himself on communication skills and the rapport that he establishes with his patients. He's authored a number of scientific papers in the areas of neurodegenerative disease, ocular pharmacology, and acquired macular diseases. He also has numerous presentations at the Academy of Ophthalmology and the Association for Research in Vision and Ophthalmology, and is a board member for the Charlotte Ophthalmology Society. Dr. Kuruvilla is married and enjoys spending time with his wife and children, and also enjoys football, outdoor activities, cooking, and movies as well. We're very grateful for our partnership with the Eye and Laser Center in Lancaster and for Dr. Kuruvilla's participation with us today. And then we have with us as well Scott Reinhardt, who is Vice President for Network and Business Development for Atrium Health. Atrium is a non-for-profit healthcare system operating more than 45 hospitals in the Carolinas and Georgia. The system has 65,000 employees and more than 2,000 medical providers. Scott oversees developing Atrium's network and working with partner organizations across its service area with an emphasis on access and sustainability. The company recently embarked on an effort to improve healthcare and access in rural areas of the state, something that's very near and dear to our heart at Lions Vision Services as well. Scott has been with Atrium for almost 8 years and worked for over 25 years with both not-for-profit and for-profit health systems in 5 states. He served as Director of Strategy and Planning for the Mississippi Baptist Health System and worked at Health South in Alabama. Scott has a bachelor's degree in professional accountancy with an MBA from both Mississippi State University, both from Mississippi and Mississippi State University. He's also earned a master's in healthcare administration from the University of North Carolina. Scott has also been active in community affairs, including Habitat for Humanity, where he's assisted in the building of 9 houses with Stupot Community Services, which provides food and other services for the needy in Jackson, Mississippi. He is treasurer for the Fort Mill Emergency Management Services. Scott and I are both also currently members of the class of 2022 for the Leadership South Carolina program as well. So Scott, Dr. Kuruvilla, thank you so much for being with us today, for taking time out of busy schedules to help us with this conversation. So I'd like to just start with getting your perspectives in your unique fields, both in vision health and then in public health, to help us frame today's conversation. Tell us a little bit about your work and what your industry looked like before the COVID-19 pandemic. For instance, what were the challenges that you were facing before COVID? What was the general tone or atmosphere in your field? How did you approach partnerships? What did you think about working with others? And what was your outlook prior to the coronavirus? Dr. Kuruvilla, would you like to start first and then Scott?
Sure, I'm happy to. And thank you for inviting me. It's always interesting to see perspectives on this from different angles and see where we can work together and what we can do to improve. As far as the challenges we were facing, it's funny, we were just talking about this at our morning kind of meeting with the staff here, how things have changed in the last, I guess, 2 years now. I mean, we've been kind of having to deal with different challenges. The things before COVID, really, we weren't different from many other doctors' offices or hospital programs. I think, we always faced a compliance issue with patients, one with medications, two with visits. Unfortunately, from an eye standpoint, especially a retina standpoint, we do need frequent visits with patients. A lot of retinal issues are chronic issues. and it's not uncommon to have a patient who needs to come in every month for treatment or for monitoring. So that becomes burdensome to the patient for sure. We do deal with a lot with the elderly population as well. So, having them come in for monthly visits, transportation becomes an issue, mobility becomes an issue. And it all interplays with their eyes as well. As your eyes and your vision deteriorate, then mobility and transportation become more of an issue. You might get to the point where you can't drive anymore, and then you have to rely on help to come to the visits, and so it can cycle out of out of control. As far as from just a medical standpoint, medicine's always on the on the defensive with Medicare cuts and all the things we deal with insurance companies as well. So that those challenges really have not changed too much, but and then as far as you mentioned what was the tone or the atmosphere in the field pre-COVID, it's the same as any other field of medicine. You always are kind of trying to stay up with the changes, in medicine so you can take good care of your patients, and two, in administration so you can make sure you're complying with all the guidelines that you need to for Medicare, Medicaid, a variety of other insurance programs. So I think those are the main things pre-COVID, and that we continue to face.
Absolutely. That's very helpful insight for us. Scott, what did that look like for you, particularly in the public health sphere?
I think a lot of similar challenges. I mean, I think from a health system perspective and a not-for-profit, it's how do we solve for access? And in particular, we started this sort of journey to look at rural care and how we deliver rural care across the Carolinas before COVID. So as we looked at that and sort of how it intersects, I mean, a lot of the social determinants, diabetes prevalence, and how do you best manage those populations in more remote areas, and how do you provide for access and appropriate access? And it does necessitate the need to partner with public, private, not-for-profit, community, health departments, you name it. You've got to figure out the ecosystem, and every community is a little different. To help solve for those needs, and those needs that are specific to each community. I think COVID amplified a lot of those situations, and we'll get into a little bit of what we saw and what happened during COVID in terms of people deferring care and all sort of downstream. But I think as we were going into COVID, it was a big challenge. I think the challenge is even bigger now as we come out of that. Payment is always a big barrier to access for people. So what does a community look like in terms of their coverage of their patients in the community, and that's a huge determinant how they access care. So I think what we're seeing in the healthcare space is those the vulnerability, even of what you would consider large secure health systems. I think across the country, they're looking at themselves and saying, well, gosh, how vulnerable am I really? How can I withstand these sort of headwinds going forward? And so I think you're going to continue in that sense to see that. I think when we'll talk about it, we found very quickly that the public healthcare infrastructure is not equipped to tackle a challenge like COVID as was the private by themselves. So we had to come together. And it was interesting, we sort of sit on the border to see how different states attacked that differently and worked. In many states had different approaches that were very successful in different ways. So that was interesting to see play out as well. But I think, again, similar challenges. I think the socioeconomic challenges that impact healthcare and people's access were the biggest ones. And those are the ones I see going forward as well.
Absolutely. Scott, you kind of teed us up there, so why don't you lead us into the conversation of how did COVID impact your work and your industry? What did your operations look like, and what did some of those changes look like in your world?
I mean, I think the first priority was how do we keep our employees safe? Obviously, as a healthcare delivery network with that many employees, how do we keep them safe? How do we just get PPE? I mean, that was the biggest immediate situation. We had to pretty much stop. When you disrupt about 90% of your operations immediately, and you have to sort of reinvent on the fly how you do things. So how we intake patients into a facility changed. I mean, everything changed about how we deliver care in a very rapid time. So the number one thing was how do we keep our employees safe? Obviously testing early on was the big thing there too. So how do we work with the public, the state, local, and private organizations to develop a system to effectively test the population and be able to diagnose and isolate people appropriately. So that was a big sort of early piece of it. Obviously, as the farther we got into it, that sort of changed to administering treatment and then now more recently vaccines. So some of the big things that we focused on early, like we were able to set up testing sites, but then we noticed that we were testing at disparate levels, so the underserved populations were not being tested appropriately. So we had to develop strategies to target underserved areas of the region to make sure we were eliminating those disparities, rather with racial or ethnicity. And so that was a big focus of what we tried to do as well. And we were deliberate about working with state and local governments as well as private industry in trying to facilitate more effective and efficient testing early on, and then that went into vaccinations as well.
Gotcha. Dr. Kuruvilla, what did that look like in your world? You mentioned some of the clients that you see with retina issues. How did that in particular, but more broadly beyond the retina issue, how did you deal with clients in an industry where social distancing is a difficult thing to do?
Yes. So honestly, it was a daily challenge in the beginning. We had to get creative. Same issues, PPE. I mean, we were in the beginning, we were making our own PPE before it was really a guidance that everyone should wear masks for these situations. So, it was me and my wife in my kitchen making masks out of rubber bands and bounty paper towels in the beginning. I mean, any kind of barrier was better than nothing in the beginning. And with the retina patients, they need their treatments. We had to figure out a way to get them in the door. We actually had to furlough a number of our staff, not just for financial reasons, but to just keep the environment safe. I mean, the more people we had in the beginning, we felt like, the higher risk it was. So we had a very bare bones operation. It was, me and maybe, 5 people, and, the other doctors as well. But we would get the patient in, get them in a room, do a very basic exam and make sure they got their injections so they wouldn't lose their vision while this was going on. So, and a lot of that, we learned over time that, we could operate in a higher capacity safely. So, so it's changed quite a bit. And now our staff is largely vaccinated. So, we're kind of back to a little bit of pre-COVID levels, but we still take an abundance of precaution with masking, with sanitizing, making sure our waiting area is not overutilized as well. So some of those changes have persisted. And we do see again the disparity in patients who come back with severe complications because they weren't able to come for their visits, didn't have transportation, and might have been impacted financially by the COVID crisis as well. It's very unfortunate. In those situations, you could have prevented some severe vision loss, but it's just we try to do the best we can, and I'm sure they do as well to come in for these visits.
Absolutely. And that probably creates a whole new outlook and perspective on where a person in that situation is going to go from this point forward, having a more severe vision impairment than might have otherwise happened if that had been caught and treated earlier. That kind of segues into our next question here, which has to do more with where we are now. So bringing us forward to the current situation, particularly what challenges are you facing today? And are you still seeing the same kind of tone or atmosphere in your field? Has your outlook changed on the other side of COVID, either for better or for worse? Dr. Kuruvilla, would you like to start us on this one?
Sure. Some of the challenges that we didn't expect pre-COVID or during COVID even, one maybe overlooked one is just vaccine hesitancy among staff and patients. That was not something I anticipated. I would have hoped once we had the vaccine, it would have really provided a route to back to normal, functioning, but we did face a bit of vaccine hesitancy. We educated as much as possible within our staff, and largely we were successful in that avenue. And also with patients too, we do our best to try and educate them as well. It's unfortunate. I had a lot of close patients who passed away unvaccinated from COVID. So that was part of the challenges. Now less so. I think it is improved, with our staff and with patients. But and then one of the biggest challenges now is staffing, and I think that's nationwide. Trying to find reliable staff who can keep our business flowing and keep the patients coming in and out. With wage pressures and everything as well, it just becomes more of a problem coming forward. So I think that's impacting overall the ophthalmology field, and I hear that from my colleagues as well. That staff that they might have had for years, might be changing their careers in kind of a later aspect due to some wage pressures, and we've tried to head that off by just keeping an open line of communication. I think one of the biggest parts of staff dissatisfaction is not being able to relay their concerns and all that. So we've been fortunate, but it's certainly a challenge going forward too, I think.
Absolutely. Scott, what does that look like for you? And I guess adding a layer based on Dr. Kuruvilla's response there, do you foresee the vaccine hesitancy that we've encountered spilling over to other types of medical treatment in a post-COVID context, or do you feel that that's fairly isolated?
Well, I mean, I think I think number one is one of the things we see coming out of it is how comfortable are patients still today. It's one thing when you're sick to, okay, I've got to go to the doctor, but how much deferred preventative care is still out there because people aren't totally sure or feel comfortable, and that's something I don't know that we know the full impact of what's a deferred mammography mean, or whatever that screening is, and what's that mean downstream a couple of years out in terms of that. The vaccine, I think staff fatigue and just stress is still there. I mean, as these waves sort of continue, we struggle with staffing. The vaccine hesitancy is real. I mean, I think the last numbers, just to give some perspective, at Atrium with almost 70,000 employees, I think they had almost everyone, but maybe it was under 1,000, but maybe 600 or 700 employees that had not either gotten an exemption or vaccinated. That was right before, and I don't know what the final number was. So we had pretty good adoption towards the end of our mandate. But it's still, it's a personal issue, and I see both sides of that. So it's a struggle I think we're going to continue to deal with. But on the flip side, I think there's some really good things that have come out of this. I mean, as we talked about needing to reinvent how we do care, we were always, I would say, ahead of the curve a little bit on virtual care. And I think what this has done is open the door on both ends of health systems to solve for the need to treat patients in a different way, but also patients' willingness to adopt and say, okay, well, maybe I never did this virtual care, whatever that means, but they've done it or been forced to do it. Now they're like, hey, it's not so bad to not have to go sit in a waiting room with a bunch of sick people. I can do this type of visit with my provider virtually. We were able to develop a whole hospital at home model where we were able to keep patients out of the hospital and treat them in their home a lot more effectively. So I think there's some advancements coming out of it, and I think some policy changes that were forced that I think will be lasting. That'll help the delivery of care going forward across all disciplines. So I think that's a good change that's come out of it.
Absolutely. So with that, what gaps do you see now? There have been some positive consequences from this, some negative consequences from this. The landscape is obviously very different. So what gaps exist in your field today, and how are you thinking about those gaps?
Yeah, I think a lot of the same challenges are still there. So you're one of your opening slides around the social determinants and what drives some of the issues they're still there today. And I think it's only compounding with the inflation we're seeing and the economic pressures that people see, how that translates into their health care. And so those are still there. I think the role of what's the place of public health versus a private not-for-profit system, and where do we intersect, and where do we sit, and what's our position to help solve some of these issues. I think those questions are still unanswered totally. But I think it's forced us to have to work in different ways and to be more creative. So I think that discussion and dialogue will continue, and will continue to be a good dialogue. But I think those are still present as I look at it. So I mean, I think the fundamental changes or the fundamental issues are there. But I think access is the number one. When I look at rural areas, urban or rural underserved areas, access is the number one thing. And so I think that's what we've got to try to continue to solve for.
Absolutely. What do you think, Dr. Kuruvilla? And I'm particularly interested in the gaps portion of your answer, just because of our space in this arena as a nonprofit that's focused on vision health. What gaps do we need to be mindful of?
No, I agree completely that access is probably one of the toughest things. And there's to me there's two two kind of categories of access. One is just physical access. Can you get to a doctor? Is there a doctor available near you who specializes in what you need? And that part, seems, I think that part seems okay. The transportation becomes an issue there. The other thing is access, as in financial access. Do you have access with health insurance, and can you meet copays? And we have a number of assistance programs, and which is great. Commission for the Blind, they help us out with some of these injections. There's copay assistance programs for those, and that's very helpful as well. And certainly Lions Club. And the other portion of that is the gap that I see, and this is kind of specific maybe for what we do, but we have an uninsured population that we can provide access for through certain assistance programs, but an uninsured patient who's an immigrant or not a citizen, unfortunately, that we don't have great tools for them. And that's difficult when you might be able to save this person's vision, and typically we end up just having to take on the cost for those things. You don't want to not treat someone who needs treatment. So but if there was a pathway for those folks, and there might be one that exists, I'm just not aware of. But we do find with our Hispanic population, there's a number of uninsured non-citizens that we can't get great care for, and end up losing them to follow up because of cost issues.
Absolutely. I think that problem is fairly widespread. Scott and I heard a little bit in some of our sessions last week about that, and access for individuals who are either immigrant status or refugee status, are real challenges that there are no easy solutions for right now. But those gaps still exist nonetheless. How does that impact your approach to partnerships in today's climate? What do you look for in a partnership, and what does an ideal partnership entail? Do you have any examples from your work that you might be able to point to help bring that to life for us? I guess maybe Scott first and then Dr. Kuruvilla.
Yeah, I mean, I think you want to work with as we try to solve for health needs in our particular field. How do we look to community services and community to fill a lot of those gaps and those social determinants? That's a big piece. So whether it's from areas of communities where there's gaps or food deserts, how do we partner with organizations that can help fill those needs? Or whether there's transportation issues, we look to partner with local organizations that can help fill those needs. For instance, in COVID, we partnered with a lot of the churches to try to, that was one of the ways in which we did outreach to initially do testing in some of these underserved communities, but also then to transition to delivering vaccines. So I think, as I said earlier, every community is a little different and has different resources they bring to bear in different local organizations, and some are more cohesive than others. And so there's not like a one size fits all sort of approach. I think you have to just understand the nuances of every community and understand how they match up against the needs and gaps that are there, and kind of sort of meet the community where they are and trying to solve for a lot of those issues that are there.
Absolutely. Before we move on from that, Scott, do you think that the decline in church attendance might impact the reliability of that faith community and of churches of being an effective community partner in years to come?
It could in certain communities. I definitely think that's a real piece, but I think it still plays a vital role in many communities. So I think it's one of the pieces you have to look at. It's not, I think as we change and people's patterns change and how they interact, and you just have to sort of move with it. And again, every community is a little different. So I think in one community, the church community might be more effective than others, and it just depends on the community you're in.
Fair enough. Thank you.
Yeah.
Dr. Kuruvilla, what's your perspective on that?
We welcome any and all partnerships because whatever we can do to help patients get what they need, and we've worked in the past with Commission for the Blind. They've been very helpful in getting patients the surgery that they need, covering hospital copays and things like that, so we have access to the operating room. And then, as I mentioned, some of these assistance programs for some of these medications that I have to inject, I can usually provide free medicine for certain folks in a certain income bracket and things like that. But the biggest thing for us is ease of access to and really just awareness of these programs as well. Sometimes we're not aware of certain programs that might exist out there. So obviously we're certainly strained for time. So whatever we can do to get our staff acclimated with these programs and reduce the paperwork component of them. It really helps us on the front line to provide access in an easier way.
Absolutely. Time is the great equalizer. We all only have so much of it. Thinking specifically about the context of vision and eye health, how can vision and eye health be incorporated more intentionally into public health initiatives? We understand that limited resources and competing priorities are often driving factors there, but how can we better incorporate vision and eye health in public health?
Obviously, I think it's very important. The impact that one person having drastic change in their vision, if that person was the primary earner for the family, it really impacts the whole family and downstream from that as well. I think awareness is probably one of the biggest things, incorporating vision screenings into the free clinics and routine screens. I used to work with a organization called Unite for Sight during medical school, and we'd just go to free clinics and provide just vision screens. It's amazing the people that don't realize that their vision's declining, and it just does it in such a gradual way that they don't realize it till it's too late. So just being on the front lines of that, and just knowing there's a problem is the biggest barrier to getting people help. So I think, that's one of the biggest things people can do.
Excellent. Those are very helpful and practical steps that we can take. Scott, what do you think?
I think just more broadly, I think awareness in whether it's eye health, oral health, whatever. I think people often overlook, and I think the other side of that is, and I was looking at one of the questions around what are some of the things that can be done. I think people's access to have covered services is important. And we live in North Carolina, South Carolina, Georgia. This whole region is did not expand Medicaid for there's good arguments on both sides of that, but there's a direct correlation with that and health status and really honestly the economic viability of small hospitals. And so I think in when the hospital goes, so does the whole medical community. And I think so. I think just awareness and then how do we advocate for the right funding to provide coverage for certain services or two big components, regardless of what particular issue you're talking about. I think those are key drivers.
Absolutely. We've been getting a lot of questions in the chat, so I wanted to transition a little bit so that we have time to address some of those. I'll try to group some of these and condense some of these together. But I think the first one is a pretty broad question for both of us, or for all of us, I should say. Over the last 1.5 years, what's been the major differences in treating patients between for-profit and nonprofit healthcare providers? I'm sorry, actually, Scott, that's probably more directly connected to your work.
Yeah, I mean, I think obviously there's for-profit healthcare organizations, and they do great work every day. I do think you saw in the pandemic a lot of the large and small not-for-profit health systems step up and fill that need in communities, and there's just more of them. And so I think the missions, in Atrium, we definitely have a for-all mission. I think that really showed through in times like this. And so they did the things without asking, well, how am I going to get paid? It was just, we've got to do this because it's the right thing and we'll figure it out. And so I think you did see that. Not to say that many for-profits didn't also step up and do their part in their community as well too. So that, I'm not trying to say that. I know from my perspective. And again, it was interesting to see in North Carolina, the state worked with a lot of the large health systems, not-for-profit health systems, to really fill some of the public health gaps. South Carolina did the same, and some states worked through the National Guard to fill the gaps differently. So it was interesting to see that play out. But I think the not-for-profits though did fill the gap as much as anybody did.
Dr. Kuruvilla, did you see that in your work as well? Did you find other nonprofits particularly in the Lancaster area, stepping in to help fill some of the gaps that existed there over the last 1.5 years?
Yeah, certainly. I think there's more flexibility on their end probably as well. We do the best we can with our limited resources, but we certainly have to consider the bottom line on certain things as well. So, MUSC just recently moved into the area as well. So, we did find that working with them, providing even during the COVID efforts, they were great in providing care for our patients when we could. But from an eye standpoint, really we're very specialized, and it's not that we can send patients who need specific eye treatment over to the hospital. It's medical school, you get very limited eye training. So, the ER doctors are more than happy to call us and ask for advice. And so it's a specific niche in that area that I wish we could, we could get additional help from other sources. But if we're the only eye care provider around, specifically as medical doctors versus optometry, there's certain things that only we can do, and we're happy to work with folks in that regard. But the nonprofits have helped us certainly in some of these patients who couldn't get care.
Absolutely. I like to think that's one of the many redeeming qualities of the nonprofit arena is a great degree of innovation and nimbleness to quickly move from one situation to another, particularly in the context of a crisis. We've certainly seen that. This is a great segue to that. It's the best kind of question I think that we like to hear from our audience. So what's the greatest current need in South Carolina that you, the healthcare providers, would like to see addressed by South Carolina Lions Clubs? Is that financial contributions? Is it eye screenings? Is it improved communication between Lions and medical providers to better meet needs? Is it something else? I'm combining a couple of questions in the follow-ups there. But what's the greatest need that you would like to see South Carolina Lions address?
For me personally, I mean, from a very focused viewpoint, because my patients come in with severe vision loss, and these retinal conditions need immediate treatment. It would be providing the medicines that they need. Certain medicines that we can do injections of to reverse some of the damage that's done. It becomes a chronic issue. These patients need injections monthly until maybe their diabetes is under control or the eye has a chance to heal. And that becomes, very taxing financially on the patient. Like I mentioned, there are some resources to get some medicines for free, but they're not available for everybody. So, there's nothing worse than, watching a patient who couldn't afford maybe something and didn't come back in a timely manner, and watching that person lose their vision. So yeah, any access to funding for these patients that can provide some of these treatments is always very much appreciated.
Yeah. Dr. Kuruvilla, are those Avastin injections that you're referring to there? Yes,
Avastin is the off-label medicine that's kind of the initial treatment that I go to. The actual on label is about 10 to 20 times more expensive, and it's really equally effective. Now there's a different on label that's actually more effective, and some people who fail Avastin, I switched to that one. And it's the Avastin versus Lucentis is the other medicine that I mentioned. Is a big trial called the CAT trial found that they're equally efficacious, but one is much cheaper than the other. So that is usually my go-to. But yeah, that's the medicine that can reverse some of the damage done by diabetes, done by macular degeneration, done by vein occlusions.
Yeah, that's been a recurring challenge for us as well, just because of the indefinite nature and high cost of those treatments. Those are hard things for us in our world right now. Scott, what about you? If the Lions of South Carolina, and I guess of North Carolina as well, and in your area, could fix your challenges or problems, how could they do that?
Well, I think any organization like this is that being the advocate for policy change at sort of a state level is always important. But it sounds to me too, I would suspect is helping provide some of those resources to help people find the resources that are available to them. I suspect many people don't know, well, you qualify for this, and this that can help fund this. So that's probably, I would suspect, a piece that's probably missing out there for people.
Absolutely, and that fits with the issue of access that we've seen coming up regularly in our conversation today. This question is geared specifically to Dr. Kuruvilla. Do you encounter patients in your practice who are believing or acting on faulty information that they found on the internet? How do you go about combating that? It seems like this has been exacerbated since COVID and is a big threat to public health.
Yeah, always, unfortunately, and even pre-COVID. But Dr. Google is not always your friend. But yeah, in this, and it really depends on your relationship with the patient. I mean, hopefully you've had enough time to build a trusting relationship with them. And we do find that when we recommend something, or that they'll at least consider it. But even with my staff, it took a lot of convincing on some people, for some people to realize that maybe what they're reading online is not the truth. And I don't blame them. I mean, they're inundated with data and different opinions from reputable sources sometimes as well. So it really just goes down to, do you have the time to sit with that person and kind of explain where you're coming from, and have them realize that you care about them, not about a policy or an agenda, that you're actually talking to them. So some of that is making sure you build these trust relationships, which again becomes harder as you having to see more patients, but it's very important, and we always try to make time for that. And then some people you just can't, and that's okay too. You still have to respect them, respect their decision, and realize, let them know you're still there for them. You don't want to terminate a relationship because of their beliefs as well. That's not helping anything. So and every time they come in, you open it up to questions, and hopefully you can answer them and help them to make the right decision.
Those are some very wise words. Scott, do you have anything to add to that from your experience, or perhaps what you've heard from healthcare providers at Atrium?
Oh, I think it's always a challenge to balance what people can find on their own versus what's real, and trusting their medical providers. So I think that's it's the sign of sort of the environment we're in today, and what people have access to, and especially with COVID and everything that's out there with vaccines and treatments and that sort of thing. I mean, I think the trust that people have with a provider, and I think we're more transactional now in a lot of cases than maybe we used to be as a society with our providers. So to the degree that we can sort of change that and make it more of a personal and develop that level of trust with their provider is important. But yeah, I feel for a physician sitting in an office with a patient coming in that's sort of researched everything ahead of time, and think they know the solution. So I think that's just any field for sure.
Yeah, absolutely. We'll kind of bring this to a close with one final question. This is a good, tangible, action item oriented question that we can leave on. And the question is there any news concerning vision treatment in the current bills being discussed in Congress, Medicare reform or others? Scott, your point about advocacy, what can we do to really move the needle forward on that? I know there's a South Carolina Senate bill that would include or add hearing aids to the list of Medicare reimbursable expenses that would significantly improve access to hearing aids in that regard. But I would love to hear your perspectives either on a state level or a national level. What bills are being discussed, and how can people contact their representatives to advocate for those?
Go
ahead. Sorry, I was actually going to just defer to you because I'm not entirely sure.
Well, I mean, I would say just more kind of philosophically, what we do is we're looking at some of the solutions is how do we look at this from both a federal and state level, and what are those things that can help move the needle? So some of the things around access for in our world, how do we ensure that virtual care is covered? I mean, in a lot of cases, it was done out of necessity or done just because it was cheaper. but reimbursement's going to drive behavior, and so the degree we can improve coverage. So I think, whether it's whatever it is in terms of coverage points, at a state, and that's sort of a state Medicaid level, but at a federal Medicare level, it's important, and it's important for any alliance to sort of coordinate across other states as well too, to try to move the needle. And these things don't happen overnight, I think is the thing we've found. And so it takes incremental, and getting at a state level, getting champions within your congressional or your legislative caucus to champion your cause, and building those coalitions is important to do as well. But virtual care has been a huge one for us in getting coverage for that.
That's very helpful. Thank you for that, Scott. I really appreciate the time that both of you have given. I see one of our friends, Mr. Drucker, here is asking about college football. I won't bring that into the conversation here, but can connect offline and continue that if you'd like. So Dr. Kuruvilla, Scott, thank you both for the work that you're doing. Thank you for your time and your perspective. We really appreciate your expertise and for being a part of this conversation today.
Thank you.
Thank you all. Have a great day.
Bye.
All right. Thank you, everyone. Have a wonderful afternoon, and stay tuned for ways to join our 2022 series of virtual events. Thank you.